All right, everybody. Thanks for coming today. We'll probably have some more folks filtering in as we go, but let's get started. Thanks for coming and welcome to today's evidence-based health policy project briefing on falls prevention among older adults and ongoing work at the University of Wisconsin-Madison to address this problem facing our state and our nation. I'm Sam Austin. I'm the EBHPP project director. Thanks to all of you for joining us today. We have a great panel that will highlight community academic partnerships at UW-Madison School of Medicine, Pharmacy, and Nursing. And we're glad to be able to showcase this interdisciplinary work during Falls Awareness Month, which is occurring both nationally and under Governor Walker's declaration here in Wisconsin. Before we get started, I'd like to briefly introduce the Evidence-Based Health Policy Project. The goal of the project is to connect research and expertise at the university and elsewhere into the health policy making process here at the Capitol, and to support an evidence-informed approach to policymaking through public briefings like this, through regional conversations we hold across the state, and training sessions for legislators and staff on resources to use evidence. This project is driven by the idea that ongoing dialogue and trust developing between policymakers and researchers can enhance and elevate the work of both. We work to serve as a resource at the Capitol and a resource on campus through the convening of nonpartisan high-quality events like this. The project is a unique partnership of the UW-Madison Population Health Institute, where I work, the La Follette School of Public Affairs at UW-Madison, and the Wisconsin Legislative Council. I'd like to recognize Stephen McCarthy from Leg Council and Hillary Shager from the La Follette School, who are both here today and are our project partners. Thanks also to Stephanie Marburger, who is our project assistant and keeps the project running smoothly. This project is made possible by the support of our funders, which include the Wisconsin Partnership Program at the UW School of Medicine and Public Health, the Community Academic Partnerships Corps at the UW Institute for Clinical and Translational Research, or ICTR-CAP, and the UW-Madison Chancellor's Office. Thanks to all those groups for enabling us to make these events free and open to the public. We develop these events with input from our Legislative Advisory Board, a bipartisan group of legislators represent a range of perspectives on health issues. Our current board membership are Representatives Joe Sanfilippo, Daniel Reamer, Jesse Rodriguez, Joan Ballweg, Deborah Kolstein, Paul Tittle, and Senators Devin Lemieux, Mark Miller, and Leah Vukmir. Thanks for their engagement and their participation in the program. The scope of the problem of falls is familiar to a lot of people in the room, I'm sure, today. Perhaps one of the most striking statistics to me is the fact that every 12 seconds in the United States, an older adult experiences a fall that will result in an emergency department visit or hospitalization, which means that for the hour and a half that we're here today for our program, nearly 500 Americans will have been hospitalized as a result of a fall, which is a pretty striking statistic. As we will hear today, this is a multifactorial problem which requires multi-factor solutions, including a strong policy framework. And on the front lines of enabling that policy framework are the standing committees in the state legislature on aging and long-term care. And for that reason, I'm very excited to welcome Representative Warren Petryk, who's the vice chair of the Assembly Committee on Aging and Long-Term Care, for some opening remarks and his perspective on his committee and issues of aging facing his district. Representative Petryk of Oliva has represented the state's 93rd district since 2011. Currently serves as the chair of the Committee on Workforce Development, and in addition to the Aging Committee, is a member of 6 other committees, including insurance and colleges and universities. He's a graduate of UW-Eau Claire and a proud member of the musical duo The Memories, who, if I understand correctly, have performed at over 400 county fairs over the past 40 years, which is another quite impressive feat. So thanks for your investment in policy to enable healthy aging in Wisconsin, and welcome your opening remarks. Thank you.
Thank you very much, Sam, and good morning, everyone. I want to, on behalf of all the legislators and people that work in this beautiful, beautiful office building, I want to welcome all of you to our Capitol, and thank you very much for your professional work in such an important area. It is my distinct privilege to serve as the vice chair of the Assembly Aging and Long-Term Care, and I've been on that committee for the past 6 years. When I walked into the building, I was assigned to it, and I fell in love with the work that we do, and we try to create good, solid public policy, of course, around the, many, many different things, and I'll talk about a few of those. Many of you have probably heard this, but maybe not the younger ones, but Hubert Humphrey was contemporary. When I was a child, he was already very, very active, but he once made this comment, and I like to share it with people. He just said the moral test of government is how that government will treat those that are in the dawn of life, our children, those who are in the twilight of life, the elderly, and those who are in the shadows of life, the sick, the needy, and those with disabilities. I try to keep that in mind as a goal of policy whenever we look at things that will change the lives of many people. I also look to many experts for advice. One of the great experts on aging, of course, was the comedian Will Rogers. He also said, we could certainly slow the aging process down if it had to work its way through Congress. And I would add maybe the state legislature. It is a deliberately slow and tedious process, but that's good. It really is that we welcome Representative Reamer. Glad to see you this morning, and one of my colleagues here. And so that all said, you heard that I have a background as a musician. I still try to share my gift of music with as many elderly people, especially as I can. I always joke after 45 years I sing old songs and I'm an old guy, so it fits very well. But I do many nursing homes, many appearances across the Midwest, wherever that happens. But I worked for 15 years before I got into this position with United Cerebral Palsy of West Central Wisconsin, where I did learn much about the challenges of not only disabilities and living with those challenges, but aging with disabilities is a completely different paradigm that was never really expected. My boss, for example, at UCP had CP since birth, and she's now close to 70 years old, and no one expected her to live that long. So with that comes many, many different challenges, of course, and as you all know. But thank you so much for your work on those. The committee itself has been very busy. I'm also the Workforce Development Chair, and it's amazing, and we just had a short conversation here with a young lady from Eau Claire, but the healthcare industry is facing such a shortage, and I know that isn't the focus of today, but I try to keep that in mind as I do public policy on workforce development. As baby boomers like myself retire, there will be more health care consumers. There's no doubt about that. We all agree on that on both sides of the aisle. It matters where not. I talk about this. Everyone agrees. The number of workers to provide is supposed to be the same. So that's a very, very challenging situation. In workforce, we have an aging population on about a 45-degree angle, and the birth rate is flat. So we'll need so many workers. 52,000 more job openings in the healthcare and social assistance industries by 2024. That's sneaking up on us quickly. So those challenges are not going away, ladies and gentlemen. So all of your input to how we can successfully attack that, we'll have to think outside the box, definitely. Welcome, our new guests. So with that in mind, I am working on, I'll only speak on one piece of legislation that I just authored along with Senator Harsdorf, and it is to provide relief to our state's very serious healthcare worker shortage by bringing our state's certified nursing assistant instructional requirements in line with our neighbors. Now, all we're asking is that we federalize this, and there's been a tremendous amount of pushback, surprisingly, to this, what we thought was a very common sense piece of legislation. Nursing homes, as you know, are turning away residents because they cannot find staff. This is a chronic problem in my district and across the nation, as a matter of fact. So all we're trying to do is match our federal standards of 75 hours, and much of that training can happen on the job, is what I've been told by many nursing home professionals. So 1 in 7 caregiving positions in long-term care is unfilled. That's a very challenging thing. And as we try to recruit people that work in Minnesota and in Iowa to come to our state, our wonderful state, it is a huge challenge. But there are many other things that my committee is working on. I won't speak to those today necessarily because my 4 minutes is up. And I want to just thank you very, very much. I want to let our professionals talk to this. I'm very anxious to learn from you. Thank you all, any of you that take the time to answer the call. And it really is a call to a vocation that helps so many people. So on behalf of all of the citizens of the state, we thank you for your dedication to those that are aging, and I'm very anxious to learn from you. So thank you all very kindly. Thank you, Sam, for the opportunity. God bless you all.
Well, thanks for that, Representative Petryk, and for those remarks. A couple nuts and bolts things before we begin here today. This event is being recorded by Wisconsin Eye and UW Extension. And all video and slides will be emailed to all registrants, and if you're a walk-up registrant, make sure to add an email so you get that, or an email address so you get that message afterwards. The folders you received today have several documents, including an agenda, biographies of each speaker, a list of further resources on this topic, and overviews of the EBHPP and the Population Health Institute. You also see a purple evaluation sheet that we hope you'll take a minute to fill out and leave on the table as you head out the door. We aim to be as responsive as possible, and we can't do that without your feedback, whether you're a provider or legislative staff or from the university. We want to be as responsive as we can. So without any further ado, I'll pass it off to our panel. Our first speakers will be Dr. Jane Mahoney of the UW School of Medicine Public Health and Jennifer Lefebvre of the Milwaukee County Department on Aging. You can get some more details on their biographies in your packets. They will discuss their work with Stepping On, an evidence-based program to prevent falls among older adults, and how that program is being adapted in Milwaukee County. One brief note, Melissa Bonet-Vasquez of the Medical College of Wisconsin was also scheduled to participate today, but is not able to join us today. She's dealing with urgent matters with family who live in Puerto Rico, and obviously have her family and all those affected by Hurricane Maria in our thoughts today. Though she's not here, we do truly appreciate her work to disseminate Stepping On and Pisando Fuerte in Milwaukee. I know that Jane and Jennifer will highlight that work very well. So thanks to both of you, and take it away.
Hello, I'm very glad to be here, and I thank you for the opportunity to talk about the Stepping On Falls Prevention Program. First, to give you a little background, as you heard, every 12 seconds in the United States, an adult age 65 or older has to visit an emergency room or is hospitalized because of a fall. So in Wisconsin, the burden of falls is manifested both in the dollar amount that we actually spend on hospital visits, emergency room, hospital visits for falls, and in the impact, what happens to people after they leave the hospital. So 2/3 of people hospitalized for a fall injury need to go to a nursing home for a short or a long-term stay afterwards. Wisconsin has the second highest death rate in the nation from falls. And our death rate has increased since 2000. Our fall-related emergency department visits have also increased over that time. And there are many reasons for this, but one of this is just the sheer numbers related to the aging of the population. So this slide shows you in 2010 the percent for each county, the percent of the population that was age 65 and older. And many of you have probably seen these slides before, made famous by the Wisconsin Department of Administration Demographic Services Center. Look what happens for 2030. Particularly in the rural areas up north, we are facing, as you mentioned, a huge increase in the percent of our population that is aging, without necessarily the workforce to be able to care for them. So that is going to put a disproportionate burden of falls in our rural northern population. So we have proven programs to reduce falls, but unfortunately very few get implemented. We know what doesn't work. We know that a simple falls risk screen doesn't work. There have been enough research studies to show that just a falls risk screen or a falls fare, a referral to your doctor, does not reduce falls. So that has taught us that we need to utilize proven programs. The CDC has published a compendium of falls programs that work. There's over 20 interventions that have been tested in randomized trials nationally or internationally, and shown to reduce falls in the range of about 30%. But only 3 are widely in practice in the United States. So we have a huge gap in getting things out. Of those 3, I'm going to be talking about one, Stepping On, because the work we've done in Wisconsin is responsible for it now becoming one of the 3. So Stepping On is a falls prevention program that was developed and tested in Australia in 2004. A small group, 7-week intervention that helps people understand how to practice safer behaviors, how to improve their balance, how to look for what their own risk factors are, and then reduce those risk factors. So it's for people with a history of falls who are cognitively intact. The original study showed a 31% reduction in falls, and it can be offered in any group setting by a trained health professional facilitator for people who live in the community setting. So here you can see Stepping On workshop in Wisconsin, and they're doing one of the balance exercises that they practice every week, and they're encouraged to practice at home. And one of the gentlemen has weights on, so they're encouraged to utilize weights. It also consists of small group work, looking at risk factors. Invited experts come in and discuss the different causes of falls and help older adults figure out what they can do to reduce their risk. So working with Kenosha County Aging and Disability Resource Center, we brought Stepping On from Australia to 5 Wisconsin counties in 2005. So we brought it directly from Australia because it had not been implemented in the U.S. Unfortunately, our early results showed we didn't reduce falls. So why was that? Was that due to changes that we had made to the program? That was our hypothesis, is that this program was great. People loved it. Other aging units wanted to take it on. It was starting to spread, but we thought we don't have what it takes to make it work here. So we have to figure that out. Fortunately, right around this time, the CDC came out with a research grant to actually prepare a Stepping On package for national dissemination and to examine specific research questions related to Stepping On. And of course, our research question was, how do we make it work? What do we need to do to really make it effective? So we followed a very structured format to figure that out. The first step was to develop a consensus among experts about what the key elements are that in the program that we need to make sure we keep. And the second step was then to implement it using all those key elements and make sure it was still effective and feasible. And that process involved conducting the program, changing the training and material based on what we learned, conducting it again, and then changing the training and material again, resulting in final program package that we would know how to train, implement, monitor, evaluate an effective program. And then the last step was to test it in different settings to see if that would, how feasible it would be in different settings. So I'll give you just a really brief, quick run through of our findings. First of all, to determine key elements, our goal was to understand what would make it work. And so we convened key experts, and over the course of about 6 months, they gave us a list of about 50 elements that need to be there to make an effective program. But those are things that have to do with establishing group facilitation, making sure older adults are in an environment where they can all learn, because this is an adult learning format, and then really advancing balance and strength exercises. So we went back then, retooled, and re-implemented the program, monitored fidelity, identified and implemented solutions that led to our changing the leader manual, how people would get trained, who could get trained, and who should enroll in the program. We then took it out to do research looking in different settings, and that led to a final program manual. It has now been disseminated across Wisconsin through the Wisconsin Institute for Healthy Aging, which was founded to help disseminate evidence-based programs. It's now in 66 counties, and over 13,600 participants in Wisconsin have been served. And we've trained 23, Wisconsin Institute for Healthy Aging has trained 23 other states. I just want to tell you that it does work now. Here's our data on 3,000 older adults from Wisconsin. We asked them about falls in the 6 months before they started the program and the 6 months after, and we found a 50% reduction in falls from pre to post, which is consistent with what Australia found. In a subsequent study, we also found it reduced emergency department visits for falls by 70%. So very important. Our later work has been to take Stepping On and see if we can turn it into something we're calling Stepping Online, because it's such a nice name, And the goal of Stepping Online is to keep people doing their balance and strength exercises and keep learning about falls prevention after they finish the program. We've done a small pilot study, randomized trial, and I'm just going to show you very quickly. These are very preliminary data and short of our staff. You guys are the first ones to see it. The orange is the intervention, and what we've shown is that it looks like it is improving physical performance, gait speed, and their physical health on a global scale. So if this plays out in a larger study, this will become a way to help people after stepping on continue their work through an online program. So I'm going to turn it over to Jennifer Lefevre now to talk about in Milwaukee, what is it like now implementing Stepping On today?
All right, thank you. So yes, I'm going to talk about the Stepping On program and a couple different ways that we've been implementing it in Milwaukee County, particularly working with communities of color. So we know that the program works, and we have been doing the evidence-based programs in Milwaukee County since 2008. But we really have, since last year, so since 2016, we really tried to ramp up our efforts in working with communities of color with these evidence-based programs, and particularly Stepping On. So as of last year, we started a collaboration with the Wisconsin Institute for Healthy Aging, and they hired a consultant to work with me to work in the communities of color, particularly the African American communities. And our goals were really to identify community locations and organizations where the people were going, where they were familiar and comfortable, and really get this program in their hands. So we identified churches and some senior apartment buildings to host the workshops. And then we actually used those workshop participants, or not used, but we reached out to them after they participated in the workshop to recruit them to be a workshop facilitator. And then from those host sites, we really were keyed in on maintaining those relationships to sustain the program within those sites. So it was using the host sites as really having that community presence and being a trusted source for the African Americans in that particular community, but then also utilizing those facilitators who were actual workshop participants, and they again were from the community. So that was really important. The thing with all this is this worked great with our diabetes program, but it did not do so well with the Stepping On program. So to date, we don't have the recruitment of African American health or professionals from the aging networks. We just have people that are trained as peer leaders in the Healthy Living with Diabetes program. So what we realize is that we really need to focus on those networks of health and aging professionals to recruit future leaders for the Stepping On program. And again, it has to be someone from the community who is trusted and respected and has a presence in the community. So at the time, we are continuing forward doing the Stepping On program in those areas of Milwaukee, but we are utilizing facilitators from other communities. So we know that we can be successful in it. We just have to continue working on those relationships and finding the right partners in that. So the other exciting opportunity that we're working with communities of color in Milwaukee is through the Milwaukee Christian Center. And this is a senior center that serves Southeast Asian populations. It is particularly for those who speak Hmong and Lao. And just earlier this year, Milwaukee Christian Center sent 2 of their staff who are bilingual to the Stepping On Leader training. And just this past Monday, they kicked off their first workshop. They have a second one starting in November. And we realized there as well that we were going to be facing some challenges as we were planning for this workshop, because the biggest being the program is written in English. The participants don't read or understand English. So we thought, well, we'll just translate it into their language. Well, they don't read their own language. So that became a very huge and probably the biggest challenge for us in figuring out how to implement the program in that community. So we really, staying true to the Stepping On program, of course, are really sticking as close to it as we can with as few adjustments as possible. And so we are realizing that there's a number of things we need to focus on. We need to really rely on family to help the participants in the class, to read them their handouts, to go through the material with them, and so that they don't have to be reading the handouts, because there are a lot of handouts with the program. The other thing that we are realizing is that they do well with pictures. So we are using the illustrations because there are a lot of pictures in the program. So we're using those to help people understand what the message is that we're trying to get across. The other thing that we're realizing with this population is that there's a lot of words that we have in the English program that there just is simply not a word for it. One of the most important ones in this program being balance. There's no word for balance in their language. So trying to describe to them what balance is has been a little tricky to come up with the right words, but the facilitators are doing a really great job with that. The other thing that we are realizing too with working with this population is that the facilitators really need to spend more time outside of the program with the participants, to be checking in on how they're doing with their exercises every day, to make sure that they're really grasping the concepts that were discussed in class that week. So there's a lot of additional follow-up from the facilitators to the workshop participants. And then the other area that we found that we really need to spend more time on, we just didn't have enough time trying to get these workshops, get them up and running, but we need to work closer with professionals from the Hmong and Lao communities to be our guest experts in the different areas. We have physical therapists, pharmacists, vision specialists, and community safety experts who come in throughout the 7 weeks. And if we don't have someone that speaks the language in one of those 4 areas, it means we need a translator, and then class becomes longer than the allotted 2 hours that we are given. So with that, we have a lot of challenges. We're working through them, but we realize we can't do all this in a short amount of time, considering that the workshops were already started this week. So we will evaluate once the 2 workshops are complete in November and see where things are at and how it worked out. And we are doing an evaluation process with not only the participants, but with the family members and with the host site and the staff there. And hopefully we will have some more information after that to see. We'll work with Dr. Mahoney to see how we can make some changes so that the population can benefit from it. So that's everything I have. Thank you.
Thanks. We want to go now to talking about a similar process that we have been doing to take Stepping On and adapt it into Pasando Fuerte. And this is for a similar reason. To be effective, behavior change interventions have to be culturally adapted to the population or in the setting in which you're working. Right now, there's no community-based falls interventions that are culturally adapted for Hispanic seniors. So they really have nothing. However, they face an increased incidence of hip fractures compared to non-Hispanic populations. And they're also the fastest growing ethnic group in the United States. So the need is growing for a program. And in response to that need, we actually have, through funding from Wisconsin Partnership Program and our UW School of Medicine and Public Health, have created an adaptation and tested it 3 times. So we have been able to translate the whole manual into Spanish and train bilingual leaders to lead the workshop. We did find we needed a number of adaptations similar to what Jennifer was saying. First of all, we had to shorten the content, and we also had to increase the number of sessions by 1 to make this something that would work for people who have more illiteracy and lower health literacy. There were other changes. I think we've made the program more fun. And that's one of the things that has actually been back adapted to stepping on for the U.S. population as well, is to add some element of fun, and we realize that's a key element. After adaptation, we've realized that so far our attendance has been high and seniors have enjoyed it. And we've also found from preliminary evaluation that the same beneficial changes that non-Hispanic seniors have made, the Hispanic seniors have made. So it appears to be having the same benefit and effect. So our hope is that within the next year, this will be something that is being disseminated in Wisconsin to our Hispanic populations. So in summary, I'd like to talk with you about stepping on by the numbers, because this leads a little into the consideration about policy. Unfortunately, less than 1/3 of the people in Wisconsin at risk for falls have been served to date. The reasons for that are many, but part of the reasons is the investment that is needed to get the programs out there. It requires some amount of investment, and the goal is not to have to charge seniors an exorbitant amount for it, but to have this be something that all seniors can avail themselves of. In 2015 and 2016, the state legislature here in Wisconsin invested $200,000 per year, and in that time frame, 3,689 people took stepping on. If you do the numbers, just based on what we know about the reduction in falls, this translates to 286 falls prevented. And what we know about the percent of falls that result in an emergency department or hospital visit, this translates to preventing ED charges of 218,400 and hospital charges of 2.5 million. So our goal is to serve all older adults at risk, because that is where we get the impact in public health terms. But we know that needs an investment, and this is a good investment. So as we think about how we can provide this program, there's some funding in the Older Americans Act for health promotion programs under Title III-D, but it's not enough to spread it to all that could benefit. One barrier that we're aware of is a need to compensate most of these programs are led by volunteers or retired health professionals, but still they need compensation for the training and some compensation for leading the classes. There's also additional considerations that are in play if we're going to be able to successfully spread it in minority communities. And I thought that Jennifer could speak to that a little.
Yeah, so in terms of getting the program out into minority populations, what we've seen in Milwaukee County, and again, just comparing it to the programs that we've done in predominantly white areas, is that, again, we really need to focus, and I mentioned this before, we need to focus on finding program facilitators who are trusted and respected and come from the particular community where they will be presenting the program. And so that kind of goes hand in hand with that statement that Dr. Mahoney made about the insufficient compensation for volunteers, because a lot of those people from the community who would be your ideal facilitator, they are volunteers and will need that compensation. And then we also need to really focus on the sites that we're using, because we have a lot of our African American populations in Milwaukee. They're trusted place, and trusted people come from their churches. And so in order to use the church locations as potential host sites, what we realized is that they need to have staff at the churches during the times of the programming, because they need to have the building unlocked, and someone that works there needs to be there. And so the church organization can't pay for that person to be on site during the time of a workshop. So all those things that go into making the program run in terms of staff time and resources, we need to take that into consideration as well. And then the other big thing working with the African American and other communities of color in Milwaukee, a really big barrier to people getting to these programs is transportation. And that's something we've been talking about for many years. It's nothing new, but we realize that transportation is so important. So there needs to be some sort of compensation, again, to those workshop participants so that they can get the transportation to get to these workshops. Currently, the transportation that's provided through the county aging offices is for medical doctor, dentist appointments, getting to the grocery store and things like that, but it doesn't allow people to come to the workshops. So those are the other areas, the barriers that we have seen in Milwaukee anyways, with getting these workshops into communities of color.
All right, well, thanks for that. And I think we'll probably have time for one or two questions for Jay and Jennifer. Representative Reamer, you.
Thank you. You mentioned that the legislature invests $200,000 annually in the Stepping On program. Do you know how much we invest totally in the programs designed to reduce the risk of falling? What's the sort of lay of the land there?
Thank you. That's a great question. I should clarify that the $200,000 was for 2 years, so it was a one-time. It hasn't been. It wasn't in this year's budget, unfortunately, but the $200,000 went for a number of different evidence-based programs, Stepping On, but also diabetes self-management program and chronic disease self-management program. So it's a suite of healthy aging programs that are disseminated through Wisconsin Institute for Healthy Aging. In terms of other state funding for falls prevention programs, I know Ann Vistek is in the audience and perhaps could answer that, but I am not actually aware. We do have falls coalitions, and the state facilitates a large network of falls coalitions that are on the ground in different communities. But I'm not aware of any other state funding for falls prevention.
County aging units receive money from the Older Americans Act, appropriated by the number of people that are 60 and over. The amount of Title IIID money that Dr. Mahoney mentioned is a small portion of money that county aging units can use towards a program such as this. Wisconsin did receive a grant from the Administration for Community Living, Administration on Aging, that went to the Wisconsin Institute for Healthy Aging, that again is spread across the state in a number of initiatives to help advance Stepping On. But currently there is no appropriation within the department or within the state right now that is funding falls prevention. It mostly happens on a community level at the county aging unit, leveraging multiple types of resources. So at a county aging level, they may want to engage their United Way or service organizations, use some of their other types of funding that they have in that way, if that helps answer the question.
Yeah, thank you. And the money from the federal government is for multitude, again, of health promotion programs, so not just falls prevention, Stepping On. Stepping On is, I think, the program that's most widespread in Wisconsin.
Can I follow up just quickly? There was a lot to digest in there. Just to be clear, that currently no state funding for falls prevention. I think I heard that in the description. Okay.
Right.
And just quickly, do counties fund it in a way that sort of matches funding from other sources? Or it's largely, I heard United Way in there, so sort of nonprofit funding or federal grants that come through?
Exactly. There's some
counties. Okay.
Yeah, the Older Americans Act with the federal funding goes through the State Office on Aging to the counties, and they have some of that they could use for falls prevention as well as other healthy aging programs. Other than that, each county finds its own sources, which may be from United Way, to try to supplement. And I think that lack of funding is really one of the biggest impediments to putting on the program. It's pretty low resource because we use volunteers as much as possible, but it does require some funding.
Well, thanks for that. And we'll have additional Q&A time if you wanted to circle back on stepping on, but I think we'll keep moving. Our next speakers will be Dr. David Mott of the UW School of Pharmacy and Barb Michaels with the Aging and Disability Resource Center of Brown County. They will discuss their community academic partnership, looking at how community pharmacists can help older adults modify their use of drugs that can increase the risk of falls. Thanks to both of you, and go ahead.
Thanks, Sam. The situation in Brown County, which is the reason that I'm here, is because I work in the community in Green Bay, serving Brown County, and I work with older adults every day at the Aging and Disability Resource Center. So I'm touched by those folks on a daily basis and hear and live their concerns with them. As you can see from this slide, falls are increasing in our county, and they're costly. It is our number one injury in Brown County, as reported by our emergency departments, and we have 4 ERs in Brown County. Another slice of the data is other organizations that are also monitoring falls, one of which is our largest EMS provider, which is Green Bay Metro Fire Department, which is one of 18 fire departments that serve the county. So, for example, for that fire department in 2013, they were going on 4 fall calls per day. And now in 2017, looking at a 5-month average so far, that's also increased to 5 per day. Another slice of the data is from the Wisconsin Hospital Association data in terms of the numbers being seen in the emergency departments at our 4 ERs in Green Bay. So back in 2013, that number averaged to 21 per day that was seen in the ERs, and now that is also increased on an average to 23 per day. At the bottom, you can see the costs, $14.8 million in 2013, and now an increase to 18.8, which is about another $4 million hike in a few years. Looking at another slice of the data on ER costs, this was another slice of 4-year data that shows a 64% increase in ER fall charges in our community of Brown County. So the role of the ADRC in our county, we have been involved for quite some time, a long time actually, in falls prevention in one way or another, motivated by the problem and the costs, which also bring medical providers and community organizations to the table to work on solutions and figure out what may work. But personally, working with older adults at the ADRC day in and day out, I'm also motivated by the concerns expressed from older adults directly to us. And when we offer classes, which as Jane talked about stepping on, we offer other classes on fall prevention that our medical providers offer. The classes fill, and we have wait lists, and people are concerned about it, and they're talking about it. And word of mouth spreads in a good way, which tells us it's not just a problem on paper. Older adults are concerned about it. So our coalition actually has been working on this for quite some time, actually since 2005. And the coalition has evolved over time, and it's involved the list of organizations that you can see on the slide. From our 4 Green Bay hospitals to our higher education, we're fortunate to have Bellin College, UW-GB, our technical college that also supports this effort in many different capacities. Our fire department, public health, a community pharmacy, our Northeast Wisconsin Regional Trauma Advisory Council is also very involved in it because they realize it's the number one injury. The council is made up of medical providers from the ER as well as the EMS, both police and fire. So it is a topic that's always addressed at these council meetings. The other up here is UW School of Pharmacy, which Dave Mott will talk about shortly. And then MediStar is involved with us here in Madison. Their quality improvement organization have also supported our coalition with data. And then, of course, our ADRC. The current coalition steering committee at this time, this is a visual of the logos of who is involved in terms of the decisions made on the goals that we focus around falls prevention. So it's our 4 hospitals, Bellin Health, Aurora, St. Vincent's and St. Mary's, our ADRC, and Public Health. Approaches to falls prevention that we've taken over the last quite a few years since the coalition started falls in a couple of broad areas. Consumer education. We have done and still do the stepping on classes because the evidence that Jane shares, we also visually see the evidence of how that can improve falls risk for older adults. So we are motivated to continue that program, as well as other classes that we offer. The hospitals and ADRC have prepared a common brochure that we all distribute to our customers and to their patients that provides how-to information on preventing falls. We do offer screenings to help just, again, with the general awareness of what folks can do to prevent falls, which is from balance screenings, in the community to in-home screenings that are more one-on-one with an individual in the home to create an action plan of what they can do to prevent a fall. And then a variety of media publications, which one that I highlight here is we're fortunate to have an experienced faller, is what I tag him with, the line, who's a great writer and has had falls and really wants to share his experience and knowledge with his peers, his older adult friends, to help prevent them from experiencing some of the same things that he has done as a result of a fall. We've also offered provider education in collaboration with our partners, hosting continuing education for medical providers. Most recently, in the last year, we've started to also focus on the faller and preventing a repeat fall. The stats are out there that if you fall once, you're very likely to fall again. So with our ER departments and our EMS staff, we've worked some processes and tools and put those in place to connect those fallers on site at the ER or at the home when an EMS person is picking that individual up just to get them back on a chair and then leaves, to connect them to community resources to help them prevent the fall from occurring again. And then lastly, which is really what we're working on right now to add to the mix, is to try to get greater community engagement of other professionals in the community that can help support our work and expand our reach. So very quickly, the history of doing Stepping On, we started in 2006 with the program and have continued on with it because of the results that we see. We've reached 1,700 participants or older adults since we started the program, which in some way you may say, well, that seems like a lot, but we have 43,000 older adults in Brown County that are 60 plus, so we're barely scratching the surface. It was that program and the class of the 7 classes where the pharmacist spoke that really presented to us a huge concern about medications and what that contributes to falls. Our folks asked over and over again, can we get more time with the pharmacist? Can you bring him back or her back? Can we get more one-on-one time with them to understand what their medications were contributing to their fall risk? So it was that we wanted to address that concern because we listened and started a small group of community folks that partnered together to see what we could do in a different way, utilizing pharmacists to address that concern. And that led us to Dave Mott at the UW School of Pharmacy.
Thank you, Barb. As Barb mentioned, medications are a concern for older adults. They want more information about medications, and they want the opportunity to meet one-on-one with a pharmacist to learn more and to reduce falling risks. Several medications are considered to be falls risk-increasing drugs, or FRIDs, because their use has been associated with falling. Several therapeutic categories of medications are considered FRIDs. Such medications as sedative hypnotics used for sleep, antidepressants, benzodiazepines used for anxiety, antihistamines used for allergies, anticholinergics, such as medication used to control bladder function, antipsychotic medications, muscle relaxants, and medications used to control blood pressure. There are two main effects that link FRIDs to falling. First, because FRIDs act in the brain, they can cause mental confusion, sedation, impaired coordination, and/or blurred vision. Second, some FRIDs dilate blood vessels, causing orthostasis, or the dizziness that results when you stand up too fast from a seated position. Each of these effects, alone or in combination, can contribute to an older adult falling. Unfortunately, use of FRIDs is common. A recent study my team conducted showed that nationally in 2012, over 85% of community-dwelling older adults used a FRID, and over 40% used 4 or more FRIDs. The key to improving medication safety for older adults is to have their medications reviewed regularly to assess how each medication is affecting them, to make any needed modifications, and to continue to monitor the medication effects. For several FRIDs, there are safer alternatives that can be used, or there are safer dosages that can be used that can reduce the risk of falling. Fortunately, the CDC recommends older adults at risk for falling have their medications reviewed and then modified or monitored to improve safety and reduce the risk of falling. So medication therapy management, or MTM, is a new role for pharmacists that can be utilized to review and modify medication use for older adults. Now, MTM is not the typical consultation received from a pharmacist at a pharmacy when a patient obtains a prescription. Rather, think of MTM as a medication checkup, similar to a dental checkup or a checkup at a physician's office. The goals of MTM are to ensure the use of appropriate medications, the proper use of medications, and to detect and prevent bad effects from medications. As the picture implies, during a medication checkup, a patient meets with a pharmacist, typically by appointment, and together they review the medications a patient is taking to determine appropriateness and effects. Any suggested modifications are discussed with the patient and the medication prescriber. And fortunately, the School of Pharmacy here at UW has been training pharmacy students to provide MTM for about 10 years. So with FRIDs and MTM as a backdrop, the two main questions that the partnership between Barb, myself, and others in Brown County addressed were, first, can we work together to develop an MTM program focused on FRIDs? Together we developed an algorithm and training program for the pharmacist to review FRIDs. We used evidence-based medicine to develop a list of suggested alternatives for modifications, and we developed ways for the pharmacist to communicate with patients and providers. The second question was, will the FRID-focused MTM improve medication safety for older adults? We needed to make sure that older adults would meet with the pharmacist and that the pharmacist would be effective in reviewing, assessing, and modifying FRID use to improve medication safety. These two questions were what our team focused on. Our team is listed here on the slide, and we were fortunate to receive some grant funding to help us along our way. So this is a quick overview of our study. Basically, we worked with two groups of older adults who completed the Stepping On program to test the impact of the FRID MTM program. One group, the treatment group, met with a pharmacist for up to 60 minutes to receive the MTM program, and the other group did not meet with the pharmacist. We followed each older adult for 6 months after the MTM program, looking at the medications they were taking. We expected to see more modifications of FRID use among older adults who met with the pharmacist. And here's a slide of the effects of the MTM program on stopping all FRID use. Almost 80% of FRID users stopped using all FRIDs 6 months after receiving the MTM program, compared to just over 25% of control group older adults. The differential impact is pretty remarkable. In summary, the study showed that our community academic partnership could develop a community pharmacist-provided, FRID-focused MTM program, and that the MTM program was effective in improving the safety of medication use and reducing the risk of falling among older adults. Additionally, older adults were very satisfied with the interaction with the pharmacist and found it very useful.
Just a couple of things from our perspective, living in the community and working with older adults. As I mentioned, the numbers that we have been able to touch with some of our fall prevention classes, and that it seems like a lot, yet our population of older adults is very large, with about 43,000 older adults, 60 and older in our county, which is about 14% of our population, and that's expected to grow. You saw some of the earlier slides that Jane had as well. It's expected to increase to 24% in a few years going forward. So there's a lot of awareness that needs to happen to educate folks on what they can do to prevent falls. And many things are very simple, but we need to get that awareness out there, as well as support for resources to help move that education forward. And then also we really see, having been a part of the concern regarding meds and fall risk and being a part of the research study and hearing that impact on those older adults, we really see the need for greater access to pharmacists for that annual med checkup.
Other implications center on adoption and sustainability of such services. The first deals with adequate payment to pharmacists for the MTM service. Some payment programs exist that do pay pharmacists for broadly defined MTM services, but it would be good to pay for a falls-specific MTM service. Further, Wisconsin statutes and regulations recognize pharmacists as healthcare providers and allow prescribers to delegate patient care tasks to pharmacists. It would be good to have policies that allow payment to pharmacists for these delegated tasks. This essentially is a referral process whereby physicians, other prescribers can refer older adults to pharmacists in the community for such services. We have a referral system for other allied health professionals such as physical therapists. We should work to include pharmacists in that system to facilitate patient access to care and provide payment for the referred services. Second, for community pharmacists to be an effective member of the healthcare team, they need to have access to electronic medical records with bidirectional communication. Pharmacist EMR access will facilitate review of patients' medical and medication history, as well as facilitate communication between pharmacists and other providers. In our study, pharmacists communicated recommendations to prescribers via phone or fax. This communication approach is inconsistent with the workflow of today's medical providers and impedes improving medication safety. And then third, thinking about expanding such a service to rural areas of Wisconsin. Again, Jane's slide at the beginning of showing what's going to happen with the demographics in rural areas. Policies should explore the feasibility and effectiveness of utilizing telehealth technology for pharmacist-provided MTM services, as these are important due to access constraints and fragmentation of care in rural areas. In-home or in-clinic access to a trained pharmacist via video or telephone could be a very effective means to deliver similar MTM services. Thank you.
Open up to any questions either in the audience or elsewhere. We'll have a microphone available. Let's start off then. Dr. Mott, what are the prospects for next steps for the study, either in Brown County or elsewhere?
Yeah, so we expanded a similar study into 4 other counties in the state. After we finished with our Brown County project, we went to Outagamie County, Calumet County, La Crosse County, and then also in Brown County for the second phase. And really we were involved in seeing if we could spread to more ADRC partners, more communities, and then more community pharmacies. We were successful in implementing that implementing that program in the other pharmacies. We had similar success in terms of pharmacists modifying FRID use. Now it's just trying to connect with other community partners, other community pharmacists, also have ideas of connecting with health systems in the state. Barb showed the slide of the partners in Green Bay, and I know Barb has had conversations with the health systems up there to try to talk about implementing this medication review algorithm, either for emergency department discharge or hospital discharge, or just try to expand it into ambulatory and other community pharmacies.
Dr. Mott, could you repeat one statistic that you had shared? You talked about the fall risk increasing drug and the percentage of the adults that use 4 or more.
Yeah. The study that we did, data from 2012, 40% of community dwelling older adults used 4 or more of those FRID medications.
So also for Dr. Mott, 76% that stop using the FRIDs, since they are obviously depressed patients or high blood pressure patients or a combination of such conditions, what happened? Were they switch on less risky for fall medication, or what happened to them?
Yeah, so a lot of the medications that were removed or modified actually were a lot of them were over-the-counter medications used for allergies or sleep. Medications, acetaminophen for pain with diphenhydramine, which is basically Benadryl. A lot of older adults were using those medications, so the pharmacist suggested alternatives for sleeping instead of those. In situations where you had medications like antidepressants or blood pressure medication, the focus was really on, number one, finding a safer alternative, right? There are safer antidepressants, switching patients to the safer antidepressants, and then monitoring follow-up to make sure things are okay. And then blood pressure medication, it's really about looking at the dose of that blood pressure medication, seeing if the dose can be reduced, and then monitoring for effects, especially the orthostasis, the dizziness upon standing. So you bring up a really good point, and we're not just talking about completely stopping going cold turkey. We're talking about modifying and monitoring. That's a really important piece to this.
Thank you very much for your testimony. Doctor, what's the current state of research regarding the interaction of drugs? I know anecdotally, not a professional, but I hear many people say I'm on X amount of different drugs. And I say, do you have any idea what the interaction is? And maybe some of the students can even speak to that. But is there a lot of research being done of how these things interact, what the side effects are? Which ones are, and then often they, as you say, they go off of them and they feel much, much better because of the cocktail that they're taking. So is there any research done? And maybe you can just speak to that a little bit, if you will.
Yeah, there's a huge focus on drug interactions, use of multiple medications at the same time, and the impacts on not just older adults, but all patient populations. As I'm sure our students can talk about, I know in the pharmacy school, we spend a lot of time with our pharmacy students talking about drug effects, drug interactions, how to intervene with patients, how to communicate with patients, how to identify alternative medications, how to communicate those modifications to prescribers. So it's definitely something that is at the top of the list in terms of things that pharmacists pay attention to, and other healthcare providers as well.
I think with that, we'll probably move on to our final set of speakers. We have Drs. Barb King and Lindsay Steege from the UW-Madison School of Nursing, and Shelley Vandenberg, who's a clinical nurse specialist with UW Health. I'd also like to recognize the large contingent of nursing students who you guys rolled deep, so thanks for coming today. Our final team will discuss Move-In, which is a nurse-led intervention to maintain mobility in the hospital setting. So thanks very much.
Us to present as part of this panel today. In hospital settings, 1 in 5 older adults will fall at least once during their hospital stay. And of those individuals who fall, at least 30% will incur some type of an injury, being either a major or a minor injury. Now, falls in hospitals are somewhat complex. Not only are they related to the physiologic effect of the acute illness, but also the occurrence of acute onset confusion that can occur during a hospital stay, gait instability that often happens, and the fact that an older adult is now in an unfamiliar environment. Due to the complexity of the hospital environment and the complexity of falls itself in hospitalized patients, interventions that have been successful, like moving on, that we see in the community, and even what's been done in long-term care, do not necessarily translate to a hospital environment. So that we don't really have a whole lot that we can grab from, to borrow from, and to use in our settings. Further research of falls in hospitals is really very much in its infancy. And of the studies that have been conducted, those that use multi-strategy approaches have been shown to be most promising, and of those, only a 20% reduction in falls has occurred. So currently, we have no evidence-based practice guidelines that will help hospital administrators or nursing staff into trying to come up with a strategy to prevent falls or reduce falls during a patient's hospital stay. So in 2008, the Center for Medicaid and Medicare Services enacted Never events. And the Never events were put in place to align care quality with the financial incentive. Never events are high-cost, high-volume events that should be preventable with the use of evidence-based practice guidelines. Falls with injury are one of those 8 Never events. And under the Never events, a hospital can no longer justify charging a higher level Medicare DRG to recover the costs that occur when a fall happens in their system. But a recent impact study that was done on the Never events showed that the CMS non-payment policy has had no impact at all on falls in hospital settings. Now, we know that falls are increasingly being used to judge quality of care in our hospitals. Particularly, this is true for older adult patients. And across the country, many nurses are now reporting that the message they receive is that they are to have 0 falls within their hospital system. Nurses also report that they're getting increasing pressure to maintain that 0 fall goal. And without having any type of evidence-based practice guidelines to guide their care, unfortunately, many nurses report that they use limiting patient mobility as a strategy to achieve no falls within their hospital system. So we wanted to tackle this issue of mobility within hospitals, and just a few statistics on what actually happens. Up to 65% of hospitalized older adults will lose functional independence during their hospital stay. Now, that can be as simple as losing their ability to do a basic activity of daily living, but more concerning, losing their ability to independently ambulate during their hospital stay. When we looked at ambulation, this has actually been identified as a hospital-associated disability in the literature. So many researchers have looked at, well, how often are patients actually walking during their hospital stay? And those researchers have used research-grade accelerometers to measure ambulation frequency and distance and time. And what we've discovered is that 96% of the time, patients are not engaged in any ambulation. Other researchers have shown that 83% of the time, patients spend their time lying in bed. The other more concerning factor is that we've now been able to identify that this limited ambulation and extensive bed rest is the most preventable and predictable cause of the hospital-associated disability that occurs in an older adult patient. So what happens when we put patients in bed and we don't let them move? And this is particularly true for an older adult. The most biggest issue is that there's a loss of muscle mass and strength that occurs in the lower extremity, up to 3% per day. So 10% loss of strength and mass is pretty much the breaking point for somebody being able to go home and live independently in our community setting. We also know that fainting or the sensation of feeling dizzy often occurs with bed rest, and that's due to a shift of plasma volume within the central circulation. Confusion commonly occurs with limited mobility in bed rest. Secretions pool in the lungs, so we see more incidents of pneumonias that occur, and also a decrease in the ability of the lungs to oxygenate. All of these factors lead to falls. So although a fall may not be happening in the hospital because we're not moving patients, Jane, you're going to see the falls, unfortunately, in community settings. So sometimes that fall just gets transferred to another setting, and we're putting our patients more at risk. More concerning is that these consequences occur within 48 hours of bed rest. So it doesn't take very long for this to happen to an older adult. Now, you would think it would be easy just to get a patient up to walk during their hospital stay, but actually getting patients up to walk is really quite complex. And there's multiple barriers that occur within a hospital system that have a direct impact on the nurse's ability to get a patient up and moving. Often nurses describe that they have limited resources. So they don't have the walking devices readily available on their inpatient unit so that the patient is available, I'm available, let's go for a walk, there's no walker here. So it takes time to get that device. Or they just not enough physical assistance to help getting patients up to walk. Another barrier is that there's poor communication amongst healthcare providers in terms of how often patients should walk, how far patients can walk, how much assistance do they need. Further, we have a culture within our across the United States now that organizations are prioritizing patient falls over promoting patient mobility. Patients also report that they experience multiple barriers. Many times they feel they cannot ask nurses to get them up to walk. They feel nurses are too busy or that's not something that they should be doing. Often patients are alarmed with motion alarms that keep them in place. So the alarm goes off, I'm not supposed to move, or I'm supposed to wait until someone can come to help me. And then nurses themselves experience personal barriers. Many nurses describe a fear of falls, or the fear of the repercussion that will occur if their patient falls during their care. Also, nurses feel unprepared in order to make that determination. Can this patient safely ambulate? And then how do I progress this patient?
So as Barb mentioned, she talked a lot about the challenge and the depiction of the problems and the importance of mobility in the hospital setting. And I'm going to talk a little bit about how we then developed an intervention to address these and to help overcome many of these barriers that Barb just described. So this is a complex problem, and one of the limitations of prior interventions in this area and other areas in healthcare is that they essentially are add-ons. So we're asking healthcare providers, healthcare workers to just do more without really thinking about removing those barriers that get in their way of best practice or practicing the way that they know they should in these settings. So that's where our partnership initiated, and that Barb is a nurse and a nurse researcher, and I am a systems engineer with a background in human factors. And human factors is the discipline that focuses on the design of systems or things for people. So how do we make everything work better for us as humans and what we need to perform rather than expecting us to adapt? So if you translate that to this context into healthcare, rather than asking the nurses to just take on more and find a way to make this work, how do we build the system around them and think about all of the pieces that are needed to enable them to get their patients up and walking, and then us to hopefully see those long-term improved patient outcomes, and in a way that's sustainable. So it would be able to continue after we went away and we're not there supporting the nurses in this anymore. So we used what's a well-known human factors and systems model to really guide how we design this intervention. And it's shown here. It's the Systems Engineering Initiative for Patient Safety model. And on the left, you see that it defines explicitly the different elements of a work system that you really need to think about. So the person, in this case, the nurse who we're asking to get these patients up and walking, is in the center. And we need to account for his or her biases, self-efficacy, confidence, knowledge, and then understand what tools and technology are available or not, what tasks they're being asked to do besides ambulation, what is the organization, this messaging around falls, that sort of culture, how do you account for that, and then also the physical environment and whether or not it's designed to support this activity. All of those elements work together to hopefully carry out care processes, again, in this case, hopefully ambulation, and achieve positive patient outcomes, but also positive outcomes for healthcare staff and the organization in terms of cost. So we used this model and the prior work that Barb described on what are the barriers that nurses experience and that the system has in place to patient ambulation, and designed an intervention that really had multiple components that span the system and aim to remove the barriers and then provide nurses with the resources they need for ambulation. So we had 5 components to this program. We began with the nurses themselves and provided a training program to really give them the skills and the competence that they need for engaging older adults in ambulation, and we worked with physical therapy to help provide that training. We also provided additional resources to these units in terms of having readily accessible assistive devices such as walkers or gait belts, and then also the hiring of one additional nursing assistant as a mobility aid for that unit. We added some work, some engagement artwork to the unit. We called it the Walk Around Wisconsin Pathway. So we put up visual art as a sort of cues to help the staff and the patients in ambulation pathways, as well as physical markers on the floor to allow for better tracking of distance that would support nurses in really understanding whether or not patients were progressing. So we're getting them up and we're helping really build that functional capacity rather than just losing it, as Barb noted. We looked at communication, so how we were changing how staff communicate around ambulation, making it forefront. So when they did their shift handoffs, how many times has this patient walked today? How far can they walk? What do they need? Also visible cues to both the patients, their family members, and the staff around the importance of ambulation. And then we really looked at the unit culture and, again, trying to sort of counteract and facilitate positive messages around ambulation rather than the more punitive false messaging that many staff reported. And again, the goal was to increase ambulation and look at ultimately improved health, reduced costs, and increased patient experience. And this is just a brief illustration to break up the slides a little bit here of the Walk Around Wisconsin Pathway. As you can see, the ambulation aid and a patient looking at some photos on the wall. We did have during the intervention period, the staff walked the patients far enough that they made it to Chicago by distance that we were tracking, so we gave some deep dish pizza to the staff during the intervention period. And then again, we had a change we created communication boards that were up in every patient room that really focused on ambulation as a priority.
And I will speak from the clinical side of working on the unit that we initiated this research on, and that's a hospital medicine unit at University Hospital. So we looked at what this actually, attacking all of these system barriers, what happened to the number of times that our patients walked, and how far did they actually go. So we looked at data for 10 weeks prior to the intervention phase, and you can see that in the slides here that the distance from prior to the research study definitely increased during the study, as well as the occurrences. And then for the 13 weeks post-intervention, what happened when the study team moved away. And you can see that we sustained that change. So this was approximately 2.5 years ago that we performed this research study. And looking further, I will speak more as well about how that has gone now today, 2.5 years later. But first, some patient feedback. So patients provided us lots of positive feedback too throughout this research about what they thought about this program and the way that we are attacking these system barriers. Patients really like the My Activity board in their room. It provided a visual tool to them and provided some instant gratification when they could see, oh, look, I got all my boxes checked off for the day, and I walked this far, and I was up in the chair for this long, and it allowed for them to see a visual management tool of how were they progressing in their ambulation. Also, like Barb talked about, patients feel like they're burdening staff when they call to go for a walk. So just having them vegetate in their bed, obviously the literature shows us that increases falls long term, and so having the nurses really motivate the patients, along with having that visual tool to help motivate the patients, was helpful. We actually even saw some increases in functional ability of our patients. One patient had commented that she was able to walk further than when she came in the hospital. So when she came into the hospital, her first walk, she was only able to walk 50 feet, and prior to coming into the hospital, that was her limit. And then leaving the hospital, she was able to walk 200 feet. So seeing significant improvements was sort of over the top of what we expected to find. We were hoping to prevent the functional decline, but we didn't expect to necessarily see those efforts go up. in that way. And then the pictures around the unit motivated the patients as well. So we were able to receive a grant for those beautiful pictures. And with the theme of Wisconsin, Walk Around Wisconsin, the staff really liked the pictures as well. I just had actually a guest comment on them recently. And then it also motivates patients at the same time. So, last time you made it to the Capitol photo, which is a beautiful photo of the Capitol in a sunset. Next time, let's see if we can make it to Camp Randall. And I actually even had a patient comment that there was someone in the picture of Camp Randall that they thought they might know based on the seat location. So fun there. And then, like I said, 2.5 years later, where does this bring us in terms of the number of times our patients are walking a month and the distance that they've traveled? So you can see here, October 14th was where this graph started, and that provided a little bit of pre-data for us on the number of ambulation occurrences in the green line, and then the miles ambulated with the orange bars, and where we started, and then the intervention phase in March through May of 2015. And you can see how those efforts have sustained or even improved since that research study. So that really showed us on the unit too, that as the research team fizzled away to their next projects and disseminating this literature, that we were able to sustain these changes. And I think that was totally targeted by those system interventions. The staff are even taking it one step further. Yesterday in a council meeting, they asked me if they could receive data on their own personal performance, and they're a little competitive, so they would like to see theirs compared to everyone else's. And of course, they love incentives too, so they had talked about having like a monthly competition to see who can walk the patients the furthest and the most. It's also easy to looking at this data to assume that just targeting our ambulation aide, who is an extra resource, the nursing assistant who jumped in to prioritize patient ambulation, could this all be a result of her and her priorities with ambulating patients? And we actually are able to separate that out in the data that we receive. And that shows us that on average, the ambulation aides work accounts for only 15% of the ambulation occurrences on the unit, while it accounts for 40% of the distance. So she might be able to push patients a little bit further and take them farther because she has a little bit more time, but yet at the same time, her work is only accounting for approximately 15% of the actual occurrences of ambulation on the unit.
So in our summary, the Centers for Medicare and Medicaid Services in their final rule noted that they did not have specific guidelines for fall prevention, but look forward to working with the Centers for Disease Control and with the public to start identifying research to assist hospitals. Now, as you can imagine, there's many researchers and clinicians across the country that do mobility and fall research that have raised concerns. And the concerns have been, is CMS relying on penalties to drive science, rather than relying on existing science to support improvements in healthcare delivery in our hospital systems? So given the current policy on never events in hospitals related to falls, there is mounting concerns that we are now experiencing unintended consequences of policies that have been put in place regarding that could affect mobility, especially for older adults during their hospital stay. The other concern is that only accounting the number of falls does not equate with quality of care. And there are many researchers and clinicians across the country that are now sounding the alarm that if we see 0 falls being reported from hospitals, we should be very suspicious of what's happening with mobilities within those systems. Losing the ability to independently ambulate, I think all of us in aging would agree that that's a serious and significant public health concern that largely goes unnoticed and unattended to in our hospital systems. So rather than counting the number of falls that occur, I think we need a shift in our performance metrics. More importantly, we should be looking at these functional performance measures. How far can a patient walk? How well can a patient walk? How independently are in their functional ability, not only during their hospital stay, but once they're able to go home, into wherever home may be, as a better measure of the quality of care that we can provide in our hospitals. So finally, hospitals are complex. It's challenging to do research in hospitals. It's challenging to do complicated research such like this in a hospital system. So as Lindsay had indicated, just telling nurses they need to walk patients more is not going to be the answer. We demonstrated that we had to knock down barriers first in order to get nurses secure enough and have their time freed up enough and resources available to them that they could get patients up to walk. And by using a systems-based model, we were able to demonstrate a meaningful and sustainable measure of quality of care. Thank you.
Well, thanks for that presentation. And we'll end with any questions from the audience or on this. I'll start off with a quick question on, obviously we're in the state capitol, we have legislators, legislative staff in the room, but public policy is only one part of this. So in terms of the private sector policy that's made every day in the hospitals, what would you say from your experience is the low-hanging fruit in terms of barriers? And whether it's culture shift or whether it's the barrier, what can a first step be on the private sector side?
Oh, that's a really good question. If we can't shift culture, putting all of these other Band-Aids in place probably isn't going to be as sufficient. So as we indicated, just putting a mobility person in place most likely won't make a substantial impact. So this shift towards we can't have any falls and we're going to get penalized if we have falls is somewhat dangerous right now in our hospital systems. And we are seeing that across the country. So it's changing our priorities. Instead of we can't have any falls, it's are we safely ambulating patients? Are patients getting up? And is that should be the quality metric that we should be targeting, along with patient satisfaction. I have to believe that patients are going to be far more satisfied that they get to go home and they're independent rather than I have to go to a nursing home and do rehabilitation. And I don't know if I'll get out of that nursing home. So that's, I think, our big push right now is shifting how we're talking about mobility in hospitals and then changing the fear factor. Instead of everyone's going to fall to, well, let's get them walking. What would it look like if everybody walked?
Hi, I'm Betsy Abramson, and I'm the director of the Wisconsin Institute for Healthy Aging that Dr. Mahoney and others have mentioned. I just wanted to say, particularly for the benefit of Representative Petryk and Representative Reamer, that as was mentioned, we do have the Stepping On program in 66 counties. And this past year, over 200 workshops were held throughout Wisconsin. And we're eager to work with the legislature in how we can expand that. As Barb mentioned, Brown County is one of our superstar counties, but when she mentioned the number of folks, and I did the math while you were talking, Barb, that's less than 4% of your population. So as she said, 1,700 is great, but it's nowhere near the 43,000 older folks that we need. And then I just wanted to put a face on what our nurses were talking about now as well. As my friends here in the audience here, I always bring up my own mother, who was just in UW hospital with pneumonia last week. And I do find it ironic that she came in there, probably in part got pneumonia from so much sitting at home. Got there, and she was all wired up. Every time she tried to move, all the buzzers went off, and there was a leaf on her door, signaling she could fall like leaves. And they barely let her move the whole time she was in pneumonia. And in a hospital, of course, as she left, escorted her all the way to the curb in the wheelchair. And my mom wanted to stay in the hospital a day or two longer than I think was necessary because she was worried about how she'd ambulate at falls and thought she needed more rest. And I said, no, you need more ambulation and to get going again. And that idea of putting them in a protective bubble, whether at home, we find people who take Stepping On are, of course, moving more and are less isolated now because of the experience of doing the strength and balance exercises, having a better handle on their medication, having more control over their environment, and practicing all that and implementing it all through the work that they do in Stepping On is what makes the difference. Keeping older people in bubbles, and I see that when I see my younger friends in hospitals, they're up and moving. The older people we keep all guarded around, and keeping people in that bubble does not help them when they get home. So we'd be happy to work with you.
And with those final comments, I think we'll bring today's program to a close. If you haven't done so, please fill out your evaluation forms and leave them on the table on your way out. Again, all materials and program video will be posted on our website and emailed out to everyone here today. So if you want to leave your email address on your way out, make sure you do that. Also, keep an eye on our website for upcoming programming. We are looking to do additional programming related to aging, social determinants of health, and healthcare workforce. Thanks to legislators and their staff who are in attendance today, Representative Reamer and Representative Petryk, and to our panelists for your great work and for your participation today. Thanks much for this ongoing dialogue between the campus, Capitol, and the community, and we will see you next time. Thanks.